This recorded lecture will be going over Chapter 39, Care of Women with Reproductive Disorders. Premenstrual syndrome, also known as ovarian cycle syndrome, is the presence of physical, psychological, or behavioral symptoms that regularly recur within the luteal phase of the menstrual cycle and significantly disappear during the remainder of the cycle. These signs and symptoms, which occur between ovulation and menstruation, include abdominal bloating, breast tenderness, irritability, appetite changes, fatigue, mood swings, and a fear of losing control. Management includes stress reduction, relaxation, and exercise interventions. Premenstrual dysphoric disorder, a more serious problem, is believed to be the result of abnormal serotonin responses to normal changes in estrogen levels during the menstrual cycle. Diagnosis is based on significant symptoms in a pattern throughout more than 3 months. Symptoms include depressed mood, anxiety, irritability, difficulty concentrating, change in appetite and sleep, and physical symptoms like breast tenderness, bloating, weight gain, and headaches. Strategies for self-care include stress management exercises, lifestyle changes, maintaining a healthy diet rich in complex carbohydrates and fiber, avoiding simple sugars, salty foods, and caffeine, and preventing hypoglycemia. Peer support groups, psychological counseling, and prescribed medications can also be helpful. Medical management commonly includes oral contraceptives, diuretics during the luteal phase of the menstrual cycle, and NSAIDs. SSRIs, or serotonin norepinephrine reuptake inhibitors, have been shown to be effective in long-term management. Dysmenorrhea is a painful menstruation, a very common gynecologic concern. There are 2 classifications of dysmenorrhea. Primary dysmenorrhea usually occurs 6 to 12 months after the menarche and often affects adolescent girls. The most commonly reported symptom is pelvic pain that radiates into the groin. Backache, decrease in appetite, vomiting, diarrhea, syncope, insomnia, and headache are the most common symptoms reported. A heating pad promotes vasodilation and often relieves cramps. Back massage and soft rhythmic massage of the abdomen can also relieve discomfort. Several complementary and alternative medicine therapies, like aromatherapy and meditation, can also be helpful. A balanced low-fat diet with foods that are natural diuretics, like cranberry juice, asparagus, and watermelon, can decrease edema. Healthcare providers can provide oral contraceptives, which provides relief from menstrual discomforts along with the advantages of contraceptive protection. Seasonal is an OC that provides longer periods of pain-free amenorrhea by allowing only 4 menstrual periods per year. Secondary dysmenorrhea typically occurs after 25 years of age and is caused by pelvic pathology like endometriosis, endometritis, adenomyosis, pelvic inflammatory disease, obstructive uterine or vaginal abnormalities, the presence of non-hormonal IUDs, or uterine polyps, fibroids, or cysts. The pain may occur before the menstrual period and last throughout the days of menstrual flow. Management involves treating the cause of the pelvic pathology. Temporary relief may be obtained from the same therapies used for primary dysmenorrhea. Philbenserin is for women with hyposexual desire disorder, which develops in approximately 1 in 10 premenopausal women. Because there is a potentially serious interaction with alcohol, the drug carries a black box warning and can be prescribed only by healthcare providers who have received specialized training and is available only from certain pharmacies. Some women wish to have children yet have difficulty conceiving. Preconception guidance involves gathering data about the woman and her partner to provide information necessary to make an informed, individualized decision concerning conception or fertility assistance. Screening for genetic disorders may be advisable. Primary infertility is the inability of a couple to conceive a child after at least 1 year of active, unprotected sexual relations without using contraceptives. Secondary infertility is the inability to conceive after having once conceived or to maintain a pregnancy long enough to deliver a viable infant. Approximately 1 in 8 couples in the United States have difficulty getting pregnant and/or sustaining a pregnancy, and increasing numbers of couples are seeking medical intervention. The ability to conceive depends primarily on both partners having normal reproductive physiology, physiologically and psychologically sensitive interaction, and proper timing of intercourse. Factors in men that contribute to infertility include problems with the sperm, abnormal ejaculation, and abnormal erections, as well as abnormal seminal fluid. Factors contributing to infertility in a woman include the following: ovulation problems, an abnormality in the pathway between the cervix and fallopian tube, an abnormality in the endometrium of the uterus or malformation of the uterus, tumors in the reproductive tract, or a vaginal or cervical environment that is inhospitable to sperm motility or viability. Repeated pregnancy loss can be caused by an abnormality in fetal chromosomes that results in spontaneous abortion, abnormalities of the cervix or uterus, disorders of the endocrine or immune system, infections, or environmental factors like toxic agents. Diagnostic tests include a detailed health history and laboratory tests, like serum prolactin levels or other endocrine evaluations, semen analysis, sperm antibody agglutination studies, and chromosome studies. Assisted reproductive therapies are available. Donor eggs or donor sperm can be used, making future legal challenges for custody a possibility. Success rates of ARTs vary, and the procedures are usually expensive and rarely covered by health insurance. A complete health history is needed, as well as information regarding fertility. Lab testing will be completed on both partners. Interventions you can discuss with patients regarding infertility could include actions like using water-soluble lubricants during intercourse, because these do not have spermicidal properties. Having the male partner avoid environments causing high scrotal temperatures. Stress management, nutrition counseling, and lifestyle analysis. Interventions for infertility can also involve medical therapy, like the use of drugs that stimulate ovulation. Although this is a normal progression within the lifespan of females, there are health changes and risks associated with menopause. The aging process and the decrease in estrogen levels can cause thinning of the vaginal walls, as well as dryness and itching of the vagina. These changes may result in painful sexual relations and can also lead to increased susceptibility to infections due to the vaginal pH increasing. The major health problems that occur at or after menopause include the development of osteoporosis and coronary heart disease. Osteoporosis is a decrease in bone mass that increases the risk for bone fractures. The decrease in estrogen that occurs during menopause slows bone growth, and therefore bone deteriorates and thins before new bone growth occurs. The first signs of osteoporosis are loss of height, back pain, and the development of a Dowager's hump, in which vertebrae fail to support the upper body in an upright position. The American College of Obstetricians and Gynecologists recommends bone density screening for menopausal women. Postmenopausal women are at an increased risk for coronary heart disease due to changes in lipid metabolism and a rise in total cholesterol. A physical examination, health history, lab testing, and bone density assessment can identify the presence or the risk for osteoporosis and coronary heart disease. Hormone replacement therapy was once the cornerstone of interventions that reduced the discomforts of menopause and protected women from developing coronary heart disease and osteoporosis. Research shows that HRT can slightly increase the risk of developing blood clots, stroke, heart attack, gallbladder disease, and uterine and breast cancer. A bioidentical hormone like oral estradiol, estradiol transdermal patches, or oral micronized progesterone has a chemical structure identical to hormones produced in the human body, but it is clinically synthesized from a steroidal molecule taken from wild yam or soy. Both synthetic and bioidentical hormones interact with the same estrogen and progesterone receptors on target cells, but their physiologic side effects may differ. Bioidentical hormone compounds are made by individual pharmacies and are not regulated or approved by the FDA. Some CAM therapies have been helpful in relieving specific discomforts of menopause. Homeopathy, acupuncture, and certain herbs can offer relief, but each have contraindications as well. Phytoestrogens, soy products, and vitamins B, C, and E have been shown to be helpful in relieving menopausal discomforts. Soy should not be used by women with estrogen-dependent cancers or women taking tamoxifen or aromatase inhibitors. Diet, yoga, and Tai Chi have remarkable value, and support groups are very effective in helping to manage menopause. Exercise has been shown to be of particular benefit in relieving menopausal symptoms. When the muscles, ligaments, and fascia that support the pelvic floor weaken, the pelvic organs may descend towards the vaginal orifice. This can affect the bladder, rectum, bowel, or uterus. Because the lack of estrogen results in weakening of tissue structures, pelvic relaxation syndrome is more likely to occur as women age. Heavy lifting, constipation, and obesity contribute to the weakening of the pelvic floor muscles and tissues. Pelvic surgery and the strain of vaginal childbirth can also contribute to the development of pelvic relaxation syndrome. Symptoms relate to the specific organs involved. In a cystocele, urinary frequency or incontinence is the most common. A rectocele can result in constipation, soiling, or painful defecation. A uterine prolapse can result in dyspareunia. The woman often complains of general symptoms that include a sense of fullness in the pelvis and backache. Diagnosis is confirmed by history and physical examination. Obtain an obstetric history concerning the number of vaginal deliveries and the size of the infants, which may have contributed to the present problem. A CT scan may be required if other pelvic pathology is suspected. Non-surgical management includes teaching the woman how to perform Kegel exercises to strengthen the pubococcygeal muscles that support the pelvic floor. Lifestyle changes include increasing fluid intake and a high-fiber diet to prevent constipation and maintaining an optimal weight. Hormone therapy can be prescribed. The procedure to prepare a cystocele or rectocele is called an anterior-posterior repair. A hysterectomy may be indicated. The management of pelvic prolapse includes minimally invasive surgery. Surgical repair can be accomplished laparoscopically, abdominally, or transvaginally. Multiple types of mesh are available for surgical use. Nurses should watch for complications in patients who had previous surgical repair using mesh products. Polycystic ovarian syndrome is a congenital condition in which many cysts develop on one or both ovaries and produce excess estrogen. Signs and symptoms include irregular menstruation, infertility, hyperinsulinemia, and glucose tolerance problems. Excessive hair on the body is common. Treatment includes the use of OCs to inhibit LH and testosterone production. Surgical removal of the cysts may be indicated. Dysfunctional uterine bleeding is a uterine bleeding that occurs at times other than during the normal menstrual cycle or abnormal bleeding during menstruation. Uterine bleeding may be considered abnormal if the interval between menstruations is less than 21 days or more than 45 days. The duration of menstrual flow is more than 7 days or the amount of blood loss exceeds 80 milliliters. Oligomenorrhea usually refers to menstrual periods that occur at an interval of 45 days or longer. The cause often involves a problem with the hypothalamus, the pituitary gland, or ovarian function. Hormone therapy is the treatment of choice, and the woman should be educated about the advantages and disadvantages of hormone therapy. The woman should be taught to keep close records of her menstrual cycle and associated symptoms. Amenorrhea is the absence of menstruation. Primary amenorrhea refers to women who have not had a normal onset of menstrual periods. Secondary amenorrhea applies to women who begin normal menses that later ceased. Some causes include anatomic defects like an imperforate hymen, an endocrine dysfunction affecting female hormones, chronic disease, extreme weight loss or obesity, emotional disturbances, drug side effect, excessive exercise, or poor nutrition. Goals of treatment include progression of normal pubertal development, prevention of complications like osteoporosis, endometrial hyperplasia or heart disease, and promotion of fertility. Metorrhagia is a bleeding between menstrual periods. Causes of abnormal metorrhagia include leiomyomas, uterine polyps, trauma, foreign body, malignancy, infection, or an interrupted pregnancy. The treatment depends on the cause. Nursing responsibilities include providing reassurance, support, and education. Menorrhagia is excessive menstrual bleeding or duration of the menstrual period. There are many causes, including hormone imbalances, malignancies, fibroids, infections, and the use of some drugs. Blood tests should be taken during menstruation for accurate diagnosis. Treatment of menorrhagia depends on the cause. The hemoglobin and hematocrit should always be assessed to determine the seriousness of blood loss. Tranexamic acid is a drug approved for non-hormonal treatment of menorrhagia. This oral medication works by reducing clot breakdown in the uterus. Nursing interventions include education about follow-up care, an iron-rich diet, and information on the treatment options available. Abnormal uterine bleeding is defined as a uterine bleeding not related to the menstrual period. It is often caused by anovulation and a failure of hormonal changes during the menstrual cycle. Bleeding from continuous estrogen production can also occur as a result of thyroid dysfunction, polycystic ovarian disease, infection, trauma, or neoplasm. Monitoring the hemoglobin and hematocrit is essential, and hospitalization may be required if the hemoglobin falls below 8 grams per 100 milliliters. A dilation and evacuation and endometrial biopsy may be required. Nursing interventions include educating the patient about the use of unproven CAM therapies and the proper use of OCs, providing support during treatments, and ensuring that the patient is aware of other treatment options. Commonly known as uterine fibroids, leiomyomas are benign tumors of the uterine muscle. Their growth is influenced by ovarian hormones, and they are common in women taking birth control pills. They spontaneously shrink during and after menopause. Common symptoms include backache, a sense of lower abdominal pressure, constipation, urinary frequency or incontinence, and abdominal uterine bleeding. A pelvic examination and ultrasound can help confirm the diagnosis. Medical management depends on the size and location of the fibroids, the symptoms experienced, the desire for future pregnancies, and how near the woman is to natural menopause. NSAIDs or OCs may be prescribed. Uterine artery embolization involves the injection of special pellets into selected blood vessels that supply the fibroid, resulting in shrinkage of the fibroid. Cramping, nausea, fever, and malaise may occur postoperatively as the fibroid degenerates. Postoperative pain may require an overnight hospitalization and treatment with fentanyl or hydromorphone by PCA pump. After 6 weeks, MRI can be used to confirm the effectiveness of the procedure. Postoperative teaching includes avoidance of anticoagulant drugs, including aspirin, avoiding douches, sexual intercourse, and the use of tampons for 4 weeks postoperatively, monitoring the urine output, preventing constipation, and returning for follow-up care. Myomectomy is the removal of the tumor from the uterine wall and can be accomplished by the use of an endoscope via an abdominal incision or vaginally. It is performed in the proliferative phase of the menstrual cycle and does minimal damage to the uterine lining, allowing for positive pregnancy outcomes in the future. A hysterectomy may be performed if the woman does not wish to have future pregnancies. Approximately 600,000 hysterectomies are performed within the United States annually, making this the second most performed surgery after C-section for women of reproductive age. Medical necessities for a hysterectomy include cancer, an unmanageable infection or bleeding, or a serious birth complication such as a ruptured uterus. Nursing responsibilities include providing education on the patient's options, clarifying misconceptions, and reducing patient anxiety. The postoperative teaching plan should include the current information on the advantages and disadvantages of hormone therapy, comfort measures for pain relief, and when to resume normal activities. The use of lubricants for vaginal intercourse and a plan for follow-up care should also be provided. Danger signs to report to the healthcare provider include bleeding or an abnormal vaginal discharge. Excuse me. Endometriosis is a common disorder in which endometrial tissue is found outside the uterus, particularly on the ovaries, in the rectovaginal septum, and in the pelvis and abdomen. It usually undergoes the same changes as the normal endometrium during the menstrual cycle and can bleed at the time of menses, which can cause irritation, pain, and the formation of adhesions. Other symptoms would include excessive menstrual flow, bleeding between periods, painful bowel movements, and painful coitus. Continuous hormonal contraceptive therapy or non-erythritol or other drugs like medroprogesterone acetate can suppress the growth of endometrial tissue. Continuous hormonal contraceptive treatment may be continued for 3 to 6 months. Surgical treatment may include a laparoscopy to remove adhesions or a laser ablation of the adhesions, which can preserve fertility. If the woman does not desire children in the future, a partial or complete hysterectomy and removal of all endometrial lesions is the most recommended treatment. Treatment for menopausal symptoms may be needed postoperatively. Benefits of robotic surgery include a shorter operative time, shorter hospitalization, more rapid recovery, and more sophisticated surgery. Urogynecologic reconstructive surgery, fistula repair, and hysterectomy are best accomplished by robotic approach. Inflammations or infections of the vulva, vagina, or cervix most often occur when the acid environment of the vaginal secretions changes, enabling the survival of pathogenic organisms. Risk factors that alter the bacterial flora and pH environment within the vagina include aging, poor nutrition, the use of medications like steroids, OCs, or antibiotics, and douching. Organisms can also gain entrance to the vagina through contaminated hands, clothing, loss of skin integrity from trauma or surgery, or sexual intercourse. Although Candida albicans is normally present in low levels in the vaginal area, a change in vaginal pH can lead to an overgrowth, resulting in vulvovaginitis. A history and physical examination usually reveal the nature of the problem. Lesions may be present and dysuria commonly occurs due to the acidic environment coming in contact with open lesions. The diagnosis of specific conditions may be accomplished by culturing vaginal discharge or lesions, blood tests for specific infections, or a colposcopy or biopsy of the lesion. Drug therapy will be prescribed based on the diagnosis. Teach the woman about the risk and prevention of genital infections as well as the treatment protocol for the specific infection. Infections of the lower genital tract are typically treated with local creams, vaginal suppositories, or systemic antimicrobials. Wearing loose cotton underwear provides comfort and decreases irritation. Genital infections can cause the woman embarrassment, impair her self-image, and negatively affect relationships. Providing psychological support is very important. Because many organisms that cause lower genital tract infections are spread by sexual intercourse, prompt treatment is essential to prevent the spread of infection to the upper genital tract. Providing a non-judgmental attitude will empower the woman to ask questions and seek advice. Toxic shock syndrome is a rare and potentially fatal disorder, most often caused by strains of Staphylococcus aureus that produce toxins that cause shock, coagulation defects, and tissue damage if they enter the bloodstream. It is associated with the trapping of bacteria within the reproductive tract for a prolonged time. Risk factors include the prolonged use of high absorbency tampons, cervical caps, or diaphragms. Symptoms of TSS include the following: rapid onset of hypotension, sudden spiking fever, flu-like symptoms, encephalopathy, a diffuse red macular rash, and peeling skin on the palms or soles. Treatment includes hospitalization and intensive care with supportive treatments and intravenous antimicrobials. You have an important role in preventing TSS by teaching the woman hand hygiene when inserting tampons and the importance of changing tampons every 4 hours. Vulvar intraepithelial neoplasia refers to the growth of abnormal tissue on the vulva that may be precancerous. Cancer of the vulva is rare and occurs most commonly in older women. Symptoms include red, brown, or white patches on the skin of the vulva. Treatment includes surgical removal of the pathologic tissue. Incorporation of the HPV vaccine into the standard immunization regimen for all girls and young women further reduces the incidence of this condition. Women should be encouraged to observe and report any changes in any moles or visible lesions in the vulvar area. The risk factors for cancer of the cervix include having had multiple sex partners, sexual intercourse with an uncircumcised male, starting intercourse at a young age, multiple pregnancies, obesity, and a history of HPV infection or an STI. Regular pelvic examinations and pap smears may enable early diagnosis and provide an opportunity for early and more successful intervention. The U.S. Preventive Services Task Force recommends screening for cervical cancer every 3 years for women aged 21 to 29. The American Cancer Society recommends that testing take place as follows. Women aged 25 to 29 years old should have a pap smear alone every 3 years or HPV and pap smear every 5 years. Women aged 30 to 65 should have a pap smear and an HPV test every 5 years. It is also acceptable to have a pap smear alone every 3 years. Screening for cervical cancer can stop after the age of 65 years if there has been no history of moderate or severe abnormal cervical cells or cervical cancer, and the woman has had 3 negative pap smear results or 2 negative HPV results in a row, or 2 negative co-test results in a row within the past 10 years, with the most recent test performed within the recommended interval. Treatment of cervical neoplasia may include cryosurgery, electrosurgical excision, or surgical conization of the cervix. Cervical cancer requires a hysterectomy with possible bilateral salpingo-oophorectomy, followed by radiation and chemotherapy. The most common malignant tumor of the female reproductive tract is endometrial cancer. It is a slow-growing cancer that most commonly occurs after menopause. The treatment of choice is a hysterectomy with bilateral salpingo-oophorectomy. Treatment is often complicated by the fact that many women with cancer of the uterus may be older or have chronic conditions like diabetes. Surgery is commonly followed by radiation and chemotherapy. Most ovarian tumors are benign. However, ovarian cancer is known as a silent cancer because signs and symptoms are often nonspecific or vague, like fatigue or abdominal distension with no detectable precancerous changes in the ovary. An important risk factor for the development of ovarian cancer is having a sister or mother with the disease or inheriting the BRCA1 or BRCA2 gene, which is also associated with breast cancer. Women on hormone therapy should be informed about the risk for ovarian cancer. Factors that may prevent ovarian cancer include 1 or more term pregnancies, breastfeeding, tubal sterilization, and possibly the use of OCs. Diagnosis is commonly made during a routine pelvic examination. In most cases, diagnosis of ovarian cancer is first established when the cancer is well beyond the ovary. CAM therapies can be helpful in managing the side effects of the cancer and the medications used to treat the cancer. Although the breast is not a reproductive organ, it is affected by hormonal changes related to the menstrual cycle and after pregnancy. Fibroadenomas are commonly found in teenagers and young adults. Fibroadenomas are firm, rubbery, mobile nodules of fibrous and glandular tissue that may or may not be tender on palpation. They do not change during the menstrual cycle. A fine needle aspiration or biopsy can be performed to determine the presence of cancerous cells. Fibrocystic breast changes are common during the reproductive years. An FBC is a palpable, thickening portion of the breast tissue associated with pain and tenderness. The lumps make breast self-examination more difficult and cause anxiety when located. Women with FBCs can learn to recognize the size and shape of their normal lumps and should report any changes in these findings, as well as any other changes to their healthcare provider. Treatment of FBCs is conservative and based on supportive care. Wearing a supportive bra, warm or cold compresses, or a gentle massage can help. Intraductal papilloma is the development of small elevations in the epithelium of the ducts of the breast under the areola. The ducts erode, causing a serosanguinous discharge from the nipple. Treatment includes excision of the mass and analysis of the discharge to determine whether cancer cells are present. The woman should be encouraged to express her concerns, and supportive care should be provided. Gender and aging are the highest risk factors for breast cancer. Early awareness via education, early detection available with new technology, and treatment advances have reduced the death rate associated with breast cancer. Breast cancer is identified according to the structure affected and staged according to the size and degree of invasiveness. The development of breast cancer is believed to be related to estrogen and progesterone. Genetic testing for BRCA1 and BRCA2 gene mutations continues due to identifying high-risk women, resulting in specific interventions to prevent development of cancer, like preventative mastectomy and reconstructive surgery. BRCA testing can be expensive and may not be covered by insurance. The U.S. PSTF recommends that women who have at least one family member with BRCA1 or BRCA2 related cancers be screened for genetic testing using one of the following models: Ontario Family History Assessment Tool, the Manchester Scoring System, Referral Screening Tool, Pedigree Assessment Tool, or FHS7. Most early breast cancer can be detected by mammography before it can be clinically palpated. Nipple discharge or change in the skin pattern, like dimpled skin on the breast, can also be a sign of breast cancer. Any unilateral breast change should be reported immediately to a healthcare provider. A healthy lifestyle that includes exercise and a diet rich in antioxidants and phytoestrogens, like vegetables, fruits, whole grains, and soy products, can protect against the development of many cancers. ACOG recommends the following as breast cancer screening guidance. Women at an average risk of breast cancer should be offered screening mammography starting at age 40 years. Women at an average risk of breast cancer should have screening mammography every 1 or 2 years based on an informed, shared decision-making process that includes a discussion of the benefits and harms of annual and biennial screening and incorporates patient values and preferences. Women at an average risk of breast cancer should continue screening mammography until at least 75 years of age. Tamoxifen is used to prevent recurring breast cancer and is also recommended for women at high risk of developing breast cancer because it has been shown to have risk reduction benefits. However, this drug is not recommended for the general population due to potential side effects, such as increased bone pain, photosensitivity, headache, and increased risk for pulmonary embolism or uterine malignancies. Some women who have known genetic BRCA1 or BRCA2 predispositions have elected to have prophylactic bilateral mastectomies. The decision is ultimately made by the woman after careful consideration and consultation with her healthcare provider. Treatment options are based on the type of breast cancer, stage of the disease, patient's age, physical and menopausal status, and other health factors that may affect the woman's ability to undergo specific treatment. In general, the primary treatment depends on the size of the cancer and can be initial chemotherapy to shrink the tumor, followed by surgical removal or simply surgical removal of a small tumor and varying amounts of surrounding tissue. The type of surgeries include the following: a lumpectomy, a partial or segmental mastectomy, a simple or total mastectomy, modified radical mastectomy, a radical mastectomy. A sentinel node biopsy can be performed if there is any concern that cancer cells have invaded the lymph nodes. Tamoxifen blocks estrogen by binding with the estrogen receptors. This drug is typically prescribed for 5 years. Certain drugs will interfere with the metabolism of tamoxifen and should be avoided, including SSRIs, SNRI antidepressants, some antipsychotics, and some cardiac drugs, as well as some medications for infectious disease and H2 blockers. Radiation therapy commonly is performed after lumpectomy or segmented mastectomy to destroy micrometastases and decrease cancer recurrence rates. Chemotherapy can also be considered as part of the treatment in combination with surgery and radiation. Ovarian ablation is the surgical removal or irradiation of the ovary to stop estrogen production. Plastic surgery of the breast can be performed to reduce breast size, enlarge breast size, or reconstruct the breast after breast cancer surgery. Problems related to excessively large breast include back and shoulder pain, pressure on nerves from brassiere straps, inability to buy clothing that fits, and psychological problems related to fear of ridicule or unwelcome sexual advances. The amount and degree of scarring should be discussed with the woman because the scar is determined by the technique of surgery. It is possible that milk production could be affected. Decreased nipple sensation or loss of part of the areola could also be a side effect of surgery that the woman should be aware of preoperatively. Breast augmentation can be initiated by patients who wish to improve their self-image. Breast augmentation can be accomplished by inserting a saline implant under the pectoralis muscle. Reconstructive mammoplasty creates a new breast when the natural tissue has been removed during mastectomy. A nipple or areola reconstruction provides a more natural appearance. Saline implants can be used, or skin and tissue could be taken from other parts of the body. Nursing responsibilities include frequent checking of the flaps for adequate perfusion, maintaining hydration to support flap perfusion, management of pain, and proper patient positioning as prescribed. Range of motion exercises typically begin 1 week after surgery, and lifting 5-pound weights is prescribed for 6 to 8 weeks. The nipple is reconstructed 3 to 4 months after breast reconstruction surgery to ensure that swelling is minimal. Tattooing of the nipple is a popular option rather than construction of a new nipple. Most women will need extensive education before breast surgery. Women are commonly particularly concerned about the change in their appearance after breast surgery. Talking with a Reach to Recovery volunteer or a nurse with extensive professional or personal knowledge before surgery could be very helpful. Postoperative care includes pain management, observation for signs of infection, and continued supportive and educational measures. Because breast tissue is very vascular, bleeding could be a problem. Body image issues, as well as societal focus on the breast as an identifier of femininity or sexual attractiveness, will make treatment for breast cancer a highly emotionally charged experience. Women may wish to have ongoing supportive care, and many will benefit greatly from participating in a support group and from visits by the American Cancer Society Reach to Recovery volunteers. Collaborative care can help reduce anxiety and stress experienced by the patient, allow both the patient and their partner to express their concerns openly. Lymphedema is a swelling of the arm that sometimes occurs after breast cancer surgery due to the damage to and resulting congestion of the lymphatic tract. Approximately 17% of women who have undergone treatment for breast cancer develop lymphedema. Lymphedema can become a chronic condition. Postoperative nursing interventions that can reduce the risk of development of lymphedema after a breast node biopsy or breast cancer surgery include refraining from taking the blood pressure on the affected arm, not giving injections or doing venipuncture in the affected arm, providing meticulous skin care, teaching the patient to wear gloves in the kitchen and when gardening, teaching the patient to avoid heavy lifting and wear a compression garment during strenuous exercise, and teaching the patient to elevate and exercise the arm daily. Discharge teaching should focus on the need for follow-up care, exercises to improve range of motion, prevention of infection, side effects of medical therapy, and community resources available. The standard of care is a complex physical therapy involving techniques that provide lymphatic drainage, specialized pressure bandaging, application of a compression garment, exercising, and skin care. Planning the care of a patient with a gynecologic problem depends on the specific disorder. The needs of the patient who will have gynecologic surgery include pain management, education regarding the procedure and follow-up care, infection prevention, and supportive care specific to the procedure. In the outpatient setting, women may be seen for annual visits, reproductive or contraceptive counseling, treatment of infections or STIs, prenatal and postnatal care, and a variety of other reasons. The plan of care must address education, pain management needs, emotional and physical care, family impact, cultural and spiritual influences, and financial concerns. The patient should agree to the goals and they must be communicated clearly to other healthcare providers through well-written care plans and documentation, as well as team conferences when appropriate. The patient's needs must always be addressed when implementing various aspects of the plan of care. Patient teaching should be an important aspect of each nursing contact. As hospital stays continue to become progressively shorter, women go home very quickly after illness, surgery, or childbirth. Home health nursing responsibilities include pain management, observation of the surgical site for signs of infection, or reopening of the surgical wound due to trauma or a poor healing response. Continued patient education is a key role of the home health nurse. The home health nurse can give accurate, detailed information on continued recovery and wellness as part of home care. The nurse also is commonly the primary source of information about appropriate support groups and informational programs that can be of assistance to the patient and their family. In the area of general reproductive health, low-cost women's healthcare clinics and organizations like Planned Parenthood can offer pregnancy testing, counseling and instruction on contraception and prevention of STIs, programs concerning BSE and VSE, and screening procedures like pelvic examinations and mammograms. Community care also involves educational public service announcements on radio and television, and in social media, newspapers, and magazines. These give to the public valuable information on sexual health and disease prevention and treatment. School nurses will function as key educators regarding reproductive teaching and health maintenance. Drugs, alcohol, and early sexual activity are major healthcare concerns for adolescents. A variety of programs exist for women at risk of serious diseases of the breast or reproductive organs. These programs provide both education and support groups for women undergoing treatment of serious health problems such as breast or uterine cancer, infertility, fetal loss, and other health concerns specific to women.